give 30 seconds for people to get into the Zoom room.
I'm not seeing anybody, right?
Yeah, the attendees are coming in. So,
great.
Yeah, you don't see the participants, but we have a list of participants attending. So we have so far 23 people. Right? So I'll give them just 30 more seconds and then we'll start. All right, good morning and welcome to the Department of Medicine Grand Rounds. This is a combined grand rounds. We have our colleagues from St. Joe's as well joining us. Our speaker today is Dr. Kostas Tselios. Dr. Tselios is one of our recent recruits. He came to Canada from Greece in 2014 for postdoc training in systemic lupus erythematosus. He became assistant professor in the Division of Rheumatology, Department of Medicine in 2021 at the peak of the pandemic, and is currently developing the McMaster Lupus Clinic and the Biobank, a very important project for the department. He has published extensively in the field of autoimmunity and lupus in particular, and he's going to speak to us today about antimalarial-induced cardiomyopathy. Before I pass it on to Dr. Tselios, I just want to remind everyone that if you have any question, please put it in the Q&A section. We'll come to it at the end. We'll probably have a really good discussion. And then if you have any comments or something you added in the chat, if you need to come in, I will bring you in to speak up at the end. So without further ado, I'll pass it on to Kostas. Kostas, please go ahead.
Thank you, Dr. Azam, for the kind invitation to present my work in the grand rounds of HHS. And let me start by acknowledging that we are situated upon the traditional territories of the Haudenosaunee and Mississaugas. This land is covered by the dish with one wampum agreement between the Haudenosaunee and Anishinaabeg and all of us on this land to share and care for the resources around the Great Lakes. So please take a moment to reflect and give thanks to those who have come before you on the lands on which you currently reside. Thank you for this. So as I said, I would like to share some of my work, a project I was working on before the pandemic. And I refer to antimalarial-induced cardiomyopathy, a rare complication of prolonged antimalarial treatment that was my main research project for a couple of years before 2020. So these are my disclosures, not relevant with this presentation. So the objectives of this presentation are to describe the epidemiological, clinical, and structural, functional, histopathological characteristics of the myocardium in antimalarial-induced cardiomyopathy. And I'll try to do this through a case vignette, a case presentation, my first ever case, the systematic literature review to see what is known on this entity, further studies I did with the Toronto lupus cohort, and future directions, what we can do further. So my first patient was a 74-year-old female at the time with a prolonged history of systemic lupus erythematosus since 1971, based on arthritis, pericarditis, Lehmann-Sachs endocarditis. It was characterized back in the 80s, Raynaud's disease in the background of positive anti-nuclear antibodies, plus neuropsychiatric involvement that was expressed with chorea and multiple transient ischemic attacks. Patient was treated with prednisone and warfarin with very good response. Later in the 80s, we learned that she had positive antiphospholipid antibodies. That was the time that we learned more about the antiphospholipids. The patient had a typical relapse and remitting course, as the vast majority of lupus patients, mainly with arthritis coming and going. And then hydroxychloroquine or Plaquenil was added in 2002, relatively late during her course. The dose was 5.7 milligrams per kilo. This is important, and we'll come to that later. She was clinically and serologically inactive since 2005. No major changes in medications. Patient was doing very well. We only noticed the chronic elevation of the creatine phosphokinase since 2006 at around 2 to 3 times the upper limit of normal, never with some clinical significance, no clinical evidence of myopathy. Normal EMG, we had done this, no issues whatsoever. In September 2012, she presented with an atypical chest pain. We suspected coronary artery disease, some ischemic cardiomyopathy. Troponin was negative, however. She didn't have any issues with the ECG, some left ventricular hypertrophy, left axis deviation. The hypertrophy was shown in the echo as well, but no systolic dysfunction, no significant valvular disease. She even had the cardiac MRI to assess the myocardium condition more precisely. That was normal, except for that mild left ventricular hypertrophy. So the symptoms subsided without any particular intervention. We didn't do anything. She felt better. And then 2 years after that time, she presents now with acute heart failure, like a typical picture with dyspnea, orthopnea, peripheral edema. The ECG this time around shows a new right block, a new left anterior fascicular block or hemiblock. The echo shows severe left ventricular hypertrophy, now significantly deteriorated compared to 2 years ago. Right ventricular hypertrophy, septal hypertrophy, biatrial enlargement, a restrictive filling pattern implying a significant diastolic dysfunction. And now the systolic function is severely impaired. The ejection fraction is 35%, plus is positive for troponin and brain natriuretic peptide. So the first thing to do would be to think of some ischemic cardiomyopathy. We did the angiography again, that was completely normal. We thought of hypertensive cardiomyopathy, maybe, but she had she did not have any significant hypertension to begin with. So we asked for a cardiac MRI. That was the second cardiac MRI. We had the baseline since 2012. And this time around, the MRI shows a dramatic left ventricular hypertrophy. Like the left ventricular mass index 122 from 75. So it went up almost by 60 or 70%. And some mild late gadolinium enhancement in a non-vascular pattern, non-ischemic-like. No edema, implying no acute process in the context of myocarditis or anything. And of course, no definite diagnosis. What was the clue from the radiologist? That this is a hypertrophic cardiomyopathy and probably infiltrative. And they suggested that Fabry's disease should come first in the differential, followed by amyloidosis or sarcoidosis. Fabry's disease, it's a genetic disease, inherited, but when it affects the heart, particularly in females, it may appear late in life. So that was a possibility. We were surprised to hear that, but anyway, we sent out for an extensive genetic screening, not only for Fabry's, but for other forms of hypertrophic cardiomyopathy. 62 genes in total were checked, and all of them were negative. So in our thoughts on what to do next, it was decided to go for a heart biopsy, an endomyocardial biopsy. And much to our surprise, we saw vacuolation and hypertrophy of the cardiomyocytes, as you can see here in the left panel. And then on the electron microscopy, we saw discs and concentric rings of lipid accumulation. This thing is over here. And if we had a high magnification, we show these lamellated myelinoid inclusions. These are discs one upon the other within the cardiomyocytes, and this is theoretically pathognomonic for antimalarial-induced cardiomyopathy. So the pathologic diagnosis was this. And we were surprised to hear this because it was the first time to have a patient like her in the clinic. And of course, it's hard to believe that you give a drug to our patients that is considered to be safe, benign, apart from some retinal toxicity. And then all of a sudden, this drug is causing heart failure. We didn't know what to make out of this. So whenever you don't know what's happening, you go to PubMed and you start digging. And this is what I did here. I tried to find all the cases of biopsy proven, right? Heart biopsy proven, antimalarial-induced cardiomyopathy. This is what AMIC stands for. So I found 47 patients at that time in 2018, about 20 of them with lupus, about 23 with rheumatoid arthritis, some of them with limited scleroderma. Rheumatologists know that we use Plaquenil a lot, sometimes, and not only for lupus or rheumatoid arthritis for typical cases. So the mean age of the patients was 56.4 years, the mean treatment duration 12.7, almost 13 years. And the cumulative dose was 1,800 grams for the hydroxychloroquine, 1157 for the chloroquine, both means. And this seemed to me at that time that is the most significant risk factor, the cumulative dose for the cardiomyopathy. Why I'm saying that, most of the patients were taking the typical dose of 400 milligrams for the hydroxychloroquine, 250 for the chloroquine. There were a few patients that were taking double the dose, 800 milligrams for hydroxychloroquine, and they developed this cardiomyopathy in half the time. So instead of 12.7 years, they did so in 6 or 7 years. And then there was a patient, for some reason, she was taking 2,000 milligrams of hydroxychloroquine a day. Don't know if they were trying to do something else or anything. But anyway, this patient developed cardiomyopathy in 2 years. What was the clinical presentation of these patients? In the vast majority, it was congestive heart failure, typical like our patient. 17% presented with syncope. And for the rest, there was no description of the clinical presentation. I remind you that all these 47 cases, we're talking about case reports. Some of them, there was only the pathology picture and some short description of the pathology and not any clinical, no clinical data. Anyway, interestingly, about half of them had received already a permanent pacemaker for complete atrioventricular block, most of them, or sick sinus syndrome. So you had like a small cohort of cardiomyopathy, and half of them are already on pacemaker, and this was like rather intriguing for me. I collected the ECG findings, echo findings, MRI findings, everything, right? And when I analyzed that, complete AVB was present in almost 50% of the patients, right block in 1/4, left block in 14%, the echo findings, left ventricular hypertrophy, like our patient, right ventricular hypertrophy in almost half, like our patient. Septal hypertrophy in the interventricular septum was hypertrophic in 42.9, atrium dilatation in 42.9, and then that diastolic dysfunction in almost half patients. What happened with the MRI? That was performed in 12 out of 47. It confirmed the left ventricular hypertrophy, and actually it was able to capture more patients with this right ventricular hypertrophy in 50%, and that late gadolinium enhancement, I don't know what this is still, in a non-vascular pattern, again, in 58% of the cases. In 10 cases, the authors reported cardiac troponin. 9 out of 10 were abnormal. Brain natriuretic peptide, 10 out of 10 was abnormal. I think expected, since the majority of the patients presented with acute heart failure. And then CK was elevated in 11 out of 14 patients at the same time with the presentation of the cardiomyopathy. What happened in the long term? Not in the very long term. In 1.5 months from diagnosis, almost 45%, 18 out of 40 patients died, unfortunately. And from the rest, 22 survivors, 2 had a heart transplantation. So not good. And in my question, if this thing is reversible, okay, we have a clue, we will stop the drug, we can't do anything more than that. Will this be reversible? Will this regress? Recovery of systolic dysfunction in 63.6% for the survivors. In a similar number of patients, hypertrophy regression based on echocardiograms. Histopathologic resolution in 2 patients. These 2 patients had the biopsy 2 years after the initial biopsy, and they couldn't find anything in the myocardium. Resolution of conduction abnormalities, the right blocks, the left fascicular blocks, in none. So what we learned from this when we gathered all the data and we were going through this, one, that this cardiomyopathy has some morphological and structural changes of hypertrophy, affecting both the ventricles and the septum. And usually, not usually, about 50% anyway, there is a bilateral enlargement. What's happening from the functional perspective? Impaired systolic function in the majority of patients, impaired diastolic function almost in all patients. Conduction system disorders, right block, left fascicular block, and of course, complete atrioventricular block or sick sinus syndrome. This was affecting like 50% of the patients. It's probably something important. And of course, we're talking about elevated biomarkers not specific to antimalarial-induced cardiomyopathy, nevertheless showing some damage of the myocardium. So if we're trying to say something about the possible pathophysiology, what would like a model of AMIC look like? So we need prolonged antimalarial exposure, right? Without this, you will not have that kind of cardiomyopathy. We know that hydroxychloroquine and chloroquine will lead to decreased lysosomal hydrolase activity, like an enzyme in the lysosome. This will inhibit the fusion of lysosome and autophagosome, and it will result in accumulation of phospholipids intracellularly. And this will lead to vacuolated cytoplasm. Try to remember the biopsy. I showed you a few slides before. Cellular hypertrophy and apoptosis or death. The cardiomyocyte will die. If the cardiomyocyte dies, probably it will release some troponin. And we may be able to capture this in a blood test. And then when a critical mass of myocardium is affected, you will have a phenomenon of pressure or volume overload. The brain natriuretic peptide will go up. And of course, conduction abnormalities, how else we can monitor this except for ECG for the moment. So if that was right, if that model was right, one would expect that cardiac biomarkers like troponin and BNP may be of value in capturing patients in prosymptomatic, asymptomatic states. That was my thought when I started this study. I ordered troponin and BNP in 179 unselected lupus patients, whoever was working through my door. I was measuring troponin and BNP, and this may seem like an odd number, 179, why you didn't do 200. At that time, the lab people called my supervisor and started complaining about this because it was like extra work. And we stopped at 179. What we found, about 27 patients elevated BNP, about 10 patients elevated troponin. And then from this 179, I selected the 151 without any prior cardiological history or pulmonary artery hypertension. So this patient never had a heart attack, never had any other kind of cardiomyopathy, any lupus myocarditis, any pulmonary artery hypertension, anything that could have affected the biomarkers. And even in this selected group of 151, 16 of them had abnormal troponin or BNP without any apparent explanation. I remind you, all these patients were asymptomatic when it comes to the cardiorespiratory systems. So I split this 151 to this 16 patients with abnormal troponin or BNP, and then 135 with normal cardiac biomarkers. What were the differences when it comes to the baseline characteristics of these people? People with normal, with abnormal biomarkers, were older than the controls. The disease duration was expectedly longer. They had more frequent hypertension at the time. They had more frequent abnormal CK. By abnormal CK, I mean at least 2 consecutive abnormal CK during their visits. At that time, we were following CK by protocol, not with any clinical indication. So we had the data to follow, like what is happening with the CK. The cumulative years on antimalarials for how long these patients were taking antimalarials was significantly longer in patients with positive biomarkers. And then we split the patients according to the median of the antimalarial duration. It was 5.6 years. So most patients were taking more than 5.6 years in the subgroup of patients with abnormal biomarkers. So these were the differences from baseline. And when we put all this data into the blender of the multivariate analysis, we found these factors to be associated with the with abnormalities in the biomarkers. Now, renal function negatively correlated, so normal kidney function less likely to have abnormal troponin or BNP. Diuretics significantly associated by a factor of 4.2, abnormalities in CK 4.6, and then cumulative years on antimalarials after beyond 5.6 years. It was like by a hazard, by an odds ratio of 5.4. Of course, a huge confidence interval here because of the small sample of patients. So we had the 16 patients with abnormal biomarkers out of the blue. And after that, I sent them to the cardiologist, and I really hope that some cardiologists are in the audience and will be interested in working on this and collaborating with this in the near future. So I sent them to the cardiologist, the 16 people, and 6 out of 16 were finally diagnosed with AMIC. 5 out of 16 with other causes. We found subclinical pulmonary artery hypertension. We found coronary artery disease expected, like we have seen this time and time again in systemic lupus erythematosus. And in 5 patients, we could not reach any definitive diagnosis. These patients are still monitored in the clinic. So with this 6, based on this project, and I was following the other patients as well, outside of this cohort of the original like 179 patients, and I captured 8 patients in total in these 2 years. The median age was 62.5 years, median disease duration 35, median antimalarial duration, we're talking about 22 years and not 12 or 13 as in the systematic review. And this is another biopsy from a patient who was taking chloroquine for exactly 22 years. Actually, and you can see again, electron dense myelin figure inclusions with the, within the myocardial fibers. And then in the high magnification, all these curvilinear bodies, this is supposed to be pathognomonic for chloroquine or antimalarial-induced cardiomyopathy. Fun fact about this biopsy is that the clinical information never reached the pathologist. So the pathologist did not know that the patient was on prolonged chloroquine treatment. What he wrote down in his report is that I'm not aware of this, but this is chloroquine-induced cardiomyopathy. So based on this and the previous observations of the CK and why this is relevant, and if this is relevant, of course, I would like to say a few things on two issues of this project. Antimalarial and elevated CK, is there a correlation? We didn't know. We had some impression back in 2016 that something is happening. And I thought to check this, how I checked 271 patients with elevated CK for 2 consecutive visits in the clinic and compared them to the rest of the patients in the Toronto lupus cohort with normal CK throughout follow-up. So no differences in age, gender, disease duration. Controls, the not CK patients had more active disease, increased cumulative damage compared with measured by the SLIC damage index. But the frequency of antimalarial use, cumulative years on antimalarials and dose were higher in cases. So we had approximately 16% of patients starting antimalarials to show some elevation in the CK on average 4 years after the antimalarial initiation. And again, by the multivariate, we found a hazard ratio of 3.1, 3.3 for the chloroquine and hydroxychloroquine for CK elevation. Is this important? What happened to these people after that? Okay, you show a CK, what does that mean? About half of them, like 50%, had a persistent CK elevation in the subsequent visits, in more than 80% of the visits. About 15% of them, it was up and down, and then in 35% of the patients, the CK was normalized, no further issues. Interestingly, it never went above 4 times the upper limit of normal throughout the duration of follow-up, even after 10 years. Right, only 2.5% developed some proximal muscle weakness, 4 from the persistent CK group, 1 from the intermittent CK group. And when we had like an EMG, it was degenerative. The biopsy was non-specific in 2 patients. We tried to have a biopsy, but only with light microscopy. We were not able to showcase some like antimalarial myopathy in these patients. So the thought is that if antimalarials are deposited in the skeletal muscles as well, right? But not only the skeletal muscles, but the myocardium. If there is any transporter, any cellular transporter, any membrane transporter that facilitates the entry of chloroquine or hydroxychloroquine into the myocytes. And my other issue, and I really don't know what to do with it, how to study it, is why these patients had received a permanent pacemaker. So what happened with the conduction system in this patient? Why like 50% of them were on pacemaker upon diagnosis? So I went back to the database and found the patients who had received a pacemaker in the Toronto lupus cohort. And I found about 25, the 7 patients or 8 received an implantable defibrillator because of ventricular tachycardia. And the rest received that because of severe brady-arrhythmia. And that's why I'm saying severe brady-arrhythmias here. So 18 cases, 13 with complete atrioventricular block, 5 with 6 sinus syndrome. Mean age 60 years, disease duration 22. We're talking about like the late phases of systemic lupus erythematosus, and they matched them 1 to 2 with age, sex, and disease duration controls. And when we compare these patients for any factor that could account for the arrhythmia, we found that cases had a high prevalence of coronary artery disease, okay, expected, valvular surgery. 2 of the patients had valvular surgery, and then the bradyarrhythmia was diagnosed a few days to 2 weeks after the surgery. So most likely that was the causative factor. More likely to have hypertension, more likely to have impaired kidney function, more likely to have been on antimalarials ever, and more likely to be on more prolonged duration of antimalarial treatment. I checked the ECGs of these patients up to 1 year before the pacemaking. So the PR interval was significantly more prolonged in the cases, people who received the pacemaker. They had more frequently right bundle branch block and LAFB. If you can remember, our patient, the index patient, developed this as well. And we were seeing this in other patients as well. And I was wondering if this is a pattern. So there will be some conduction system abnormality, and it will appear with RBBB, then LAFB. If a patient has both RBBB and LAFB, there's a 50% possibility that this patient will receive a permanent pacemaker in the next 5 years. And then I checked the echoes for the patients that this was available. And I found that there was an interventricular septum hypertrophy in more cases than controls. Now, if we take it by anatomy, the conduction system runs within the interventricular septum. And I was wondering if this is the case, if the myocytes there are more predisposed somehow to for more accumulation of the antimalarials. So, okay, with the multivariate again, and again, it's not like the absolute proof. Nevertheless, it says something. There was like a 13% higher possibility for every year on antimalarial treatment for the development of a severe brady-arrhythmia. And possible causes, we said 6 with coronary artery disease, 3 with valvulopathy or heart surgery, and then the arrhythmia right after. Antimalarials in 8 patients, unknown in 1. Why I'm saying antimalarials in 8 cases most likely? Because these patients had no known risk factors for arrhythmia. So no valvulopathy, no prior heart disease, no heart surgery, no nothing. They had 6 of them had coronary angiography at the time of pacemaking, and it was normal, completely normal. So we can say something about ischemic cardiomyopathy in the terms of the traditionally seen atherosclerotic disease. They had septum and left ventricular hypertrophy and diastolic dysfunction in all patients. 5 of them, 5 out of 8, had a concomitant ocular toxicity. And I still remember a patient from Sault Ste. Marie. They called me. She's taking Plaquenil for 9 years. The ophthalmologist discontinues the medication on Monday because they see something, and then Sunday she goes to church and she has a syncope. And she's taken to the emergency, complete atrioventricular block. She gets a pacemaker, and then they call us down in Toronto, help what we are supposed to do with this lupus patient. We can't use Plaquenil. So, and it's hard to convince them that, look, Plaquenil did this. Anyway, mean antimalarial duration 22 years versus 13 in the remainder of the patients, significantly important. So what happened, much to my shame, I never wrote this paper, it was only an abstract. What happened in the long term? Right, okay, you diagnose these patients, what happened? One patient died 3 months after diagnosis, like a refractory heart failure with pulmonary edema, ICU, multiple infections. Unfortunately, she did not do well. Regression, partial regression of left ventricular hypertrophy in 3 out of 4 based on the MRI, 5 out of 7 with the echo. Regression of the septal hypertrophy, 2 out of 8. Improvement in diastolic dysfunction, 2 out of 8. Conduction abnormalities, 5 out of 8 patients at diagnosis, and in no patient was this reversed over 2 years of follow-up. What we noticed actually in one patient, she got a pacemaker because of a complete block 18 months after drug withdrawal. So we stopped the drug, but still we were not able to prevent this. And then 2 paroxysmal AFibs 12 months after drug withdrawal, thankfully reversed. This is what happened over time with the cardiac biomarkers. I was following the biomarkers in these people like every 3 months when they were coming for the regular visits. And as you can see, there is a clear trend of regression. They tend to go back towards normal, but in most of these cases, this was abnormal even after 2 years. This is the patient who died here, unfortunately. Even after 2 years, it's still abnormal. When it comes to the BNP in the cases in whom we caught this early, I guess it went back to normal or almost normal in some other patients that had like a significant increase in the BNP levels. This is still abnormal. So I was thinking about this. Okay, if the plaque on the antimalarials, I'm sorry, based on the traditional knowledge, they accumulate in tissues with full of rich in melanocytes. Right. Well, what is the issue with the heart? Is it possible we have melanocytes in the heart or anything? And this comes from an experimental study, not only in animal hearts, but in human hearts here as well. And they, if I'm not mistaken, they dye the cells with pro-opio melanocortin to characterize the melanocytes, and they found melanocytes around the bulbs here, around the pulmonary veins, in the interventricular septum here, and of course, even in human hearts. And of course, the question was, what are they doing there? Why do we need melanocytes in the heart? I don't know. I don't think that anybody knows. Like a smart answer I found is that, okay, we characterize these cells as melanocytes because they carry this POMC biomarker, but we don't know what other functions these cells have. And there is a paper, I didn't include this in this presentation, suggesting that there is an ontogenetic process through which these melanocytes are related to the maturation of the cells of the conduction system. Anyway, it seems that there is a biologic substrate for this. So, okay, how important this is, like how many patients might this affect? Probably it's rare, right? I found 47 published cases. The first was in 71. The last one was like a few months before I published that systematic review. So probably millions of patients have been treated with antimalarials, and we have like 47 cases. So what? This is an experiment actually from 1983. They fed the dogs with huge doses of chloroquine, and then they sacrificed them, unfortunately, and they measured the dry weight of the chloroquine in the tissues. And as you can see here, the eye comes first. So it's highly likely that the ophthalmologists are saving our patients by capturing this toxicity. And we can see in the eye what is happening, like in the rest of the body. Because if you see lower than the eye, you will see accumulation in the spleen, lungs, liver, kidneys, then heart, and then muscles. So probably it's rare because the ophthalmologists will capture it and they will let us know. Is it true? I'm not quite sure about this. We know that the incidence of heart failure in lupus is like 4.6 times more than the non-lupus population, and this comes from a huge study in administrative databases. So you're aware of the weaknesses of the studies. Nevertheless, they found that all these cases have a definitive, like a possible diagnosis, mostly coronary artery disease or hypertension or a previous myocarditis in 20 to 35% of the cases. So in about 2/3 of our cases of lupus who develop heart failure, we don't actually know what this is. And I can recall like plenty of patients in the 60s, 70s, 75 with some heart failure symptoms. And even we tend to think, okay, you're 75, you had lupus forever. You have some hypertension, you're not taking the drugs we prescribed. So what do you expect? And then we just treat these patients conservatively, some diuretics, some ACE inhibitors, without actually wondering why this happened. So it's possible that we'll have a false and erroneous diagnosis in these patients. So from all this, what we have learned up to now, that this antimalarial-induced cardiomyopathy is a rare complication of prolonged AM treatment. If we say the opposite, will be wrong. Antimalarials are like a cornerstone of treatment in lupus, very helpful in rheumatoid arthritis and other types of inflammatory arthropathy, relatively benign compared to the other drugs we use, and so beneficial for lupus patients that the recommendations, the updated recommendations, are like every one of the lupus patients should be treated with antimalarials. Right, but can we fine-tune this treatment so we'll get all the benefits? Prolonged survival, less thrombosis, a better glycemic profile, a better lipidemic profile, and all these things, like less flares, without increasing the risk of complications to our patients. I believe that cardiac biomarkers may be an effective screening tool. And I think that patients on prolonged antimalarial treatment, we could check a cardiac troponin or a BNP every now and then to see if something is going on, regardless of symptoms. Echocardiogram, we're talking about the hypertrophy, we're talking about the diastolic dysfunction, can assist diagnosis, cardiac MRI as well. And reversibility is partial and slow, but not uncommon. Don't expect that you will stop the drug and the patient will get better next day. No, this is not going to happen. It's a really antimalarials are accumulating in most of the cells of the organism. It will take like a really long time, probably years, for this to go away. Future directions, what I'm thinking for this project. If there is any role of novel MRI techniques like the T1 and T2 mapping in the detection of this cardiomyopathy, is it possible that we'll have a heart biopsy in all patients with antimalarials? No, it's unrealistic. It's utopic. Can we check them with CMR? Probably we can. We published the last paper in 2020, that JACC cardiovascular imaging. It's this from this project, and this T1 and T2 mapping is a relatively new technique. And the conclusion of this paper was that it resembles Fabry's disease, is very much alike Fabry's disease. It's so alike that we may characterize this as an acquired Fabry's. So if this is the case, can we have like an MRI and then some genetic testing and say, look, it's Fabry's or Plaquenil, and then Fabry's is excluded by genetic testing, so it's the other one. My other thought is, if this is true, if that lyso-Gb3 metabolic byproduct, what is this? This is a metabolic byproduct that they follow in patients with Fabry's disease to assess the efficacy of treatment. So this is going up in patients with Fabry's, and if they are treated, alpha-galactosidase, if I'm not mistaken, this will go down, and this reflects response to treatment. So could this lyso-Gb3 be a biomarker of the accumulative load of antimalarials in our patients? Maybe. I was like in talks with Sherbrooke, Quebec. There is a lab there. They are working on that. We were not funded. We hope that we will be in the future. And then last, what about this conduction abnormalities? Why we will stop the drug in our patients and they will still get a pacemaker? Most likely because of this prolonged antimalarial treatment. I don't know how to study this further. So that was all for me. I would like to leave at least 15 minutes for discussion and questions. Thank you all for your attention. This is a picture from my place in Greece. I hope in August to be there, and I hope that snow will have melted away by then. Thank you so much.
Thank you so much, Kostas, for this interesting and pretty, outlining scientific thinking and finding out this new entities. So I'm intrigued by the snow in where you come from. So we have a lot of it here as well. Thank you. So there are a couple of questions, and there are also comments. There is a question about to the laminated inclusions in monocytes under the monocyte render the monocyte as cardiotoxicity. Can monocytes with inclusions be detected in peripheral blood, and does accumulation of other toxins such as iron cause similar cardiac problem?
Right. Now, the laminated inclusions, we found this in the myocytes and not the circulating monocytes. I don't know if the attendee means the circulating monocytes, because we did not detect this in the in PBMCs, but in the cardiomyocytes on the tissue. Right? If these myocytes are toxic to the neighboring myocytes, I don't know. These cells seem like metabolically inactive, and in most cases they just die. They undergo apoptosis. But for monocytes, I really don't know if these inclusions were detected in monocytes. I'm sorry. Now the iron, if iron, I guess that we are talking about hemochromatosis here. Right, that histologically is distinct from antimalarial-induced cardiomyopathy.
Thank you for that. There was a comment from Dr. Cox related to the trop rise. I don't know if you had chat in the chat talking about necrosis versus apoptosis, and apoptosis potentially not when the cell death happens, not causing troponin rise. I'm not sure if you have a comment on that one. It's in the chat.
Yes, I can see that now. The lack of elevation of troponin levels might be due to the process of cell death. So if we have apoptosis is a regulated death, right? A controlled cell death. We don't know if this is like apoptosis or plain necrosis of the myocytes, right? Apoptosis, during apoptosis, Dr. Cox, you believe that we wouldn't have troponin?
Interesting concept.
Right.
I'm going to move it to a more of a clinically practical question, from Dr. Conley, related to, when we also these patients, as you've outlined, as a cardiologist, he sees this patient antimalarials, and then what is the convincing evidence of there is benefit from then stopping the medication in terms of management of the heart failure patients?
Right. Now the evidence is far from convincing, Dr. Connolly, because we're talking about like only a handful of patients, right? I have seen regression, yes, when it comes to hypertrophy, when it comes to systolic function, even sometimes diastolic function gets better months or a few years after stopping the plaquenil. My issue is that this seems to be related to the cumulative dose. So could we get all, if you go to the lupus literature, for example, everybody says that the patients should take antimalarials forever. Now, the question is, what dose will give us the benefits we get at the least cost for complications? So could we go, for example, with 200 milligrams per day instead of 400 in the long term in patients who are inactive for so long? Most likely, Dr. Hughes in London says that, but this is like a thought, a theory, and not based on data yet.
So I'm sure in your plans to study this further, you're going to be looking at, the impact of this.
That was my goal actually for the presentation. And if Dr. Connolly and other cardiologists are interested, I would be more than happy to collaborate.
All right. There's another question. I think there are a couple of questions. Again, talking about the subcellular markers of apoptosis, which can be detected when the apoptosis pathway is activated. Can any of these markers, example, caspicins, be detected in AMIC cardiomyocytes?
That's a great question. And I think that this might be even relevant therapeutically. Now, there is only one report. They checked the caspases, caspas 1 and caspas 3, if I'm not mistaken, in these patients, and they found this elevated. So they suggested apoptosis because of this. Can we target this therapeutically for these patients? Because what we can do up to now is just stop the drug, right? There's nothing else that can be done. And I don't think that we'll be allowed to use, if we prove that this is an acquired fabris, to use that fancy treatment. It's so expensive. But I think that this, yes, maybe a good therapeutic target. Thank you for that.
Another comment and question from Dr. Gerald Cox related to, which is another thought-provoking. Could there be a safe threshold for lifetime ingestion of antimalarials that
right.
At that point we should start looking at cardiotoxicity?
This could be another good project. We don't have a safe threshold. We don't have like the golden standard here. What we know is that if we go to a 400 milligram dose, like a typical dose, this goes up to 12 to 13 years, right? Goes close to 2 grams, 2,000 grams. Correct, 2,000 grams of hydroxychloroquine. Right, but not standardized, still needs to be tested.
Something to think about, right? Thank you. That's great. Another question from Dr. Durasami related to the lack of troponin rise at times and the sensitivity, and then because of the CK elevation, should we start looking at an NB fraction of CK? It reminds me of the old days of pre-troponin times, the NB fraction.
Right. I remember this. I'm not that young. Of course, I remember this. And to be honest, I asked this from the lab in Toronto. They didn't do that because they considered troponin to be more sensitive. So they stopped doing CK-MB. So we didn't have the chance to check on it. In a few cases that was reported, it was elevated, yes.
Interesting.
I don't know. Are we doing this in HHS? CK-MB?
Not to my knowledge. I haven't seen it for more like a decade or two. We don't. Maybe experimental, like you can get it, but not routinely.
Most likely. In Toronto, they stopped doing this like years ago.
Yeah. It's not. There's no clinical utility for it right now. So.
Right.
All right. Another question, which is so do other tissues in patients on long-term antimalaria affected by laminated inclusions?
Right. It has been described in kidney biopsies, and I have seen this in patients on kidney biopsies. I have seen this in retinal from autopsies. Very, very similar in all these different cells, the kidney cells, retinal cells, the same laminated inclusions.
Thank you. That's great. I don't see any further questions or comments, unless I'm missing any, but doesn't look like. This has been really, again, very thought-provoking. Clearly, we are going to be getting more calls right now once we see patients with heart failure and on antimalarials to question.
I'm glad to pick it up again, Dr. Azam. Like if there is any interest, any possible collaborators, looking forward to it.
Yeah, potentially with our group from the heart failure clinic or heart failure cardiologist. Dr. Katie Conley, who commented, is one of them. Hey, Katie has a comment in the chat. She is lots of these patients in heart function clinic. Maybe you should connect with Dr. Katie Conley. And
I'm seeing Dr. Connolly here. Yes, of course.
Yeah, she's one of our heart function or heart failure cardiologists. So I think that would be very useful. Not seeing any further comments or questions. This has been great presentation this morning. Thank you very much for sharing your great work with us. And
my pleasure, Dr.
discussion. And looks like there's a lot more to be done for our patients. So thank you very much. I will give everyone another 5 minutes to end of the grand rounds, and have a great day, everyone. Thank you very much, Kostas, again.
Okay, thank you so much.